And then we have also 250 patients without brain mets to kind of try to understand with or without this important feature of brain mets, what is the efficacy of TDXD. And basically, I think that the big takeaway message is that TDXD works amazingly in HER2-positive metastatic breast cancer inside and outside of the brain, like both in the body metastases and in the intra-CNS metastases. We saw about 70% objective response rate and intracranial response rate in these patients, which was remarkable. The PFS and intracranial PFS were beyond 1 year, were up to 17 months.
Fantastic.
And it was very interesting to see that the overall survival in the cohort of patients with or without brain metastasis was basically the same.
Yes.
Was like the curves were the same.
Yes.
Basically showing that if you use a highly potent drug that works inside and outside of the brain, you can basically revert the adverse prognostic effect of brain metastasis. Of course, these are the first presentation of the data. We need to follow this data to see how it evolves. But I think like it's striking and really kind of closed, let's say, this question of what should we use in second line for patients with HER2-positive metastatic breast cancer.
So that's the question. That's the question. For me, that was enough. That was the data I wanted to solidify that regardless of brain mass or no brain mass, TDXD is my second line. My third line will be the HER2-CLIMB regimen. How about you? Do you still see that there is a space of doing the TTC regimen before doing TDXD, or for you also that solidified TDXD as your second line choice?
I personally don't. If you think of it, we have TDXD with 70% intracranial response rate, a PFS that exceeds 1 year, studying a large population of patients, and it's one injection every 3 weeks.